We welcome everyone today to the webinar to introduce the Mother and Baby Substance Exposure Toolkit, co-hosted by CMQCC, CPQCC, and Health Management Associates. As you join the meeting, we ask you to complete the open poll. We will share the results shortly. I am Christina Oldini, Associate Director at CMQCC and a Project Clinical Lead. Everyone on the call is muted to eliminate background noise. If you have technical issues, please type your concern in the chat function. If you have questions, please type them in the Q&A function of the platform. We will address questions at the completion of the webinar. These are the objectives for today's webinar. Our agenda today begins with the introductions of our presenters. We thank all of them for their support of this project and their presentations today. Our physician leads at CMQCC and CPQCC, Medical Director Dr. Elliott Main and Chief Medical Officer Dr. Henry Lee, will lead us off with some introductory comments. Dr. Corey Waller will then present Addiction 101. Dr. Waller, principal at HMA, is a nationally recognized addiction expert and an actively practicing addiction, pain, and emergency medicine specialist. Following Dr. Waller, Holly Smith will offer a live demonstration of the toolkit. Ms. Smith is the project manager of the initiative at CM and CPQCC and health policy chair of the California Nurse Midwives Association. Ms. Smith will then hand off to Dr. Carrie Griffin, who will cover the maternal care best practices. Dr. Griffin is a family medicine physician who specializes in maternal, child, and reproductive health and practices in Humboldt County. Dr. Kathryn Ponder will then speak to the newborn care best practices. Dr. Ponder is a neonatologist with East Bay Newborn Specialists, working in the newborn intensive care units at UCSF Benioff Children's Oakland, John Muir Walnut Creek, and Alta Bates Hospitals. Doctors Ponder and Griffin will complete the toolkit review with transitions of care content. To complete our webinar, Dr. Jadene Wong will offer the closing comments. Dr. Wong is a clinical lead on the project, clinical associate professor of pediatrics at Stanford University School of Medicine, and a neonatal hospitalist at Lucile Packard Children's Hospital. We will conclude the webinar with a question and answer session. As noted previously, questions may be typed into the Q&A section of the webinar at any time. I'd like to turn it over now to Dr. Elliott Main and Dr. Henry Lee. Doctors Main and Lee, please, we welcome your introductory comments.
Thank you, everyone, and welcome this afternoon. This is a pretty dramatic partnership of many folks involved with treating this epidemic, and it really reflects the partnerships that are needed to care for women and babies. We have community groups, prenatal providers, hospital leaders, pediatricians, addiction treatment specialists, all involved. And it's really one of our very first toolkits that has integrated mother and baby and the skills of California Maternal Quality Care Collaborative and California Perinatal Quality Collaborative, here in addition with Health Management Associates, the national leaders in addiction medicine and MAT. As you see here on the screen, the task force is very multidisciplinary with nurses, physicians, midwives, and community leads from all around the state, some 28 members of the task force, that with other authors have authored 39 best practices that we'll go over today. And it's a testament to the quality of the work that they've done that we are able to present the toolkit today. So thank everyone, and it is a lot of people, everyone, for their efforts. I'm going to turn it over to Henry. Dr. Lee. Next slide. I wanted to.
That has been. Yeah, I'm sorry, Elliot, go ahead.
No, I was, please, Henry.
Okay, no, I just want to acknowledge the internal teams at CMQCC and CPQCC. There's more than a few people involved, and you know, their names are listed here, as well as the volunteers across the state. But I just want to call out in particular the organizational leadership of our program managers, Holly Smith and Aaron Crew at CMQCC, and Carolyn Pham at CPQCC. They've just done an amazing job in coordinating the activities of this group. And Ellie, I'll let you make some final comments before we get to the content.
The last acknowledgement is that this effort has been done in the context of national efforts to address the opioid epidemic. Not only SAMHSA and other federal agencies, but we'd also like to acknowledge AIM and the California Department of Healthcare Services funding, and the ability to share our best practices with their best practices from particularly Illinois and Northern New England Perinatal Quality Collaborative, who have been there before us, shall we say, and we have been able to use a lot of their materials in the creation of our toolkit. So let me turn it back to Christina.
Thank you both, Elliot and Henry. I'm going to ask all our speakers to speak up a little bit, please. We've had some comments, so we really appreciate that. I want to take you to our polling results. We have about 400 folks that have taken the poll at this point in time, and I'm going to review our first question, which revolves around universal screening. And currently, it's almost an equal split between we do not universally screen, and yes, we both screen in both, the prenatal and inpatient sites. So almost equal between that, and that comes out to about 70%. So about 35% do not universally screen, 35% screen in both settings. Our next question revolved around utilizing a structured non-pharmacologic approach. And again, it's interesting. Almost equally split between, yes, we have a structured approach in place, and yes, we do use soothing techniques, but do not use a structured non-pharmacologic approach. So I want to thank everybody for taking the poll. We're going to go ahead and close the poll at this time, and we're going to go ahead and continue on with the rest of the webinar. So I'd like to now turn it over to Dr. Corey Waller. Corey?
Great, thank you so much. I appreciate it. And so in 10 minutes, we're gonna get some deep neuroscience on addiction, but I think hopefully it's enough to set up kind of the reason that we needed to put all of this together, and that we're treating a chronic disease of the mother, and then it has a consistent and very predictable reality of moving to the next generation if we don't stabilize mom. And that's why it was so important as we developed this to develop something that was really focused on the dyad. And I'm going to start just by talking about the basics of the reward system and how it really becomes hijacked by substances and or behaviors. If we go to the next slide, please. This is the basic breakdown of the reward system, starting with what you can see is the PAG, or the periaqueductal gray. Now, this is the part of the brain that's responsible for producing endorphins, and it has a number of other more subtle actions that it does. But for the purposes of this, this is where opioids would begin to work, in that they begin to mimic the periaqueductal gray's release of endorphins, and going up to this part that really is the core of the reward system, which is the VTA, or the ventral tegmental area, sending projections of dopaminergic neurons to the nucleus accumbens, where more dopamine is released in that central axis. that dopamine is responsible for, I guess in its basic form, motivation. And that motivation can be emotional motivation, motivation to get up and go to work, motivation to get on a webinar in the middle of the day. And if that's being done in a normal way, that then goes to the amygdala, helps to suppress our basic fear response, and lets us make decisions that are based on logic and the normal pieces of the day-to-day inputs that we get to make good decisions that feel more like a pros and cons sheet. The problem that happens when we introduce a substance or a significant behavior, and in particular things like methamphetamine or opioids, is that all of this part of the brain gets revved up. Next slide. And when we rev up this part of the brain, it has back one, please. It has a tendency to do what the brain always does when it's doing something that it doesn't want to do, which is go back to homeostasis. And when I say revved up, the average dopamine that's released on a pretty standard day, and maybe the best day ever in the nucleus accumbens, is around between 50 and 100 nanograms per deciliter. And that's kind of where we're supposed to live. But in this setting, when we start to add things like methamphetamine or opioids, it can go as high as 1,100 nanograms per deciliter. And that significant increase in the amount of dopamine produced has pretty negative impacts long-term. And if that continues to happen over and over again, what we end up with is a setup where instead of having an increase in the ability for us to create motivation through dopamine and these neurons from the ventral tegmental area and the nucleus accumbens pushing us to a good or a positive decision, we end up with the brain that is fought back over time. Next slide. And with this, what we end up with after consistent utilization of substances is a brain that doesn't have the capability to produce its appropriate endorphins. It doesn't produce its appropriate dopamine. And if it's not producing appropriate dopamine, then it doesn't create a situation where we have someone who is motivated. And that motivation is important because as we want to get someone into treatment, or we need them to care for their child, or we need them to go to work, that baseline level of dopamine is required to be able to do that. And when we have this dopamine depleted state, it has many other issues that come up from it. And some of these other issues could be you don't onboard emotional memory nearly as well. And emotional memory is also known as therapy. So if we don't stabilize the dopamine axis in the brain, then what we end up with is someone who's unable to really take on the nuances and requirements of therapy in order to be able to be productive and move through the changes required for the disease. And it creates a set of behaviors that are pretty predictable. And it's predictable enough that that's how we define the disease. Next slide. And we define the disease based on a set of behaviors. It is not diagnosed based on the presence or absence of a substance, but rather the behavior associated with obtaining or using that substance. And these behaviors can be seen over and over again. And if we look at the list here that comes from the DSM-5, we have the taking of an opioid in larger amounts and for longer than intended. Most people innately, internally will know this. Wanting to cut down or quit, but not really being able to do it, spending a lot of time obtaining the opioid, craving or a strong desire to use opioids. This is the first sign that we're going to find in someone who has an early burgeoning opioid use disorder. And many times we haven't really been able to figure it out. Family may not know about it. Friends may not know about it. And it's because that most of this portion of the diagnosis is internal. And it's about what you're thinking about and what you're, trying to do. But most people can get kind of, quote, by with these behaviors because it's mostly internal. And unless you ask through a structured screening or a structured assessment tool, we're not going to catch people at these early phases. If we look at kind of the next phase of things where it starts to really impact the people around us and the things that we do, we find repeatedly unable to carry out major obligations at work or school or home, continued use despite persistent or recurring social or interpersonal problems, and stopping or reducing important social or occupational or recreational activities. Many times this is where we start to see the outward effects of a substance use disorder. And in this case, we may find people The problem is that if we don't ask, again, we still are going to miss a large portion of the population with this disease. And by the time that we get to this more moderate substance use disorder, we really have depleted that dopamine, decreased motivation, and the craving for the substance has really taken over for the normal cravings of day to day, like just having a normal meal, taking care of a kid, going to work, and to the point where it persists long enough. And then we get this, recurrent use of opioids in physically hazardous situations, going to a part of town you wouldn't normally go to, putting yourself at high risk for sexual assault when you normally wouldn't do that. Consistent use of opioids despite acknowledgement of persistent or recurrent physical or psychological difficulties, meaning that it's making you anxious, it's making you more depressed. But despite that, the changes in the brain aren't letting you have a clear thought process about what's going on. Next slide. And so keeping that in mind really puts us in a position to be able to set up what are the best practices for how we go about getting a person, one, identified, but then two, walking through the treatment pathways, which is once you find it, then we have to provide, especially for opioid use disorder, medication for the stabilization of this disease. And interestingly, for addiction, I mean, we're 60 and 70% effective at keeping people in treatment, which is much better than the vast majority of other chronic diseases that we treat. Without medication, we don't do that. And once we keep them involved in treatment, then we can move toward that psychosocial support for the disease that is so helpful in maintaining a mother's trajectory toward a delivery of a happy, healthy baby, and then monitoring that immediately after and going home together. And then if we deliver these at the appropriate level of care, meaning outpatient or residential or intensive outpatient, then we really set up the system to stop that repetitive process that is so predictable based on behavior, but yet we felt relatively powerless to take care of. And so with this toolkit, what we've really tried to do is put out the best practices that allow us to identify, to treat, to transition properly, and then to educate everybody about it. And with that, I'm going to hand it over to Holly Smith to show you the toolkit.
Hello, everybody. Thank you for being here today. I'm Holly Smith. I'm the project manager for the Mother and Baby Substance Exposure Initiative, and I have been tasked with walking us through some of the basic features of the toolkit. Now, I only have about 5 minutes for this, so I'm going to go kind of quickly, but I think you'll find that once you get onto the site, it's very easy to use, very user-friendly, and you'll find what you need. The very first thing is to note that the URL is nastoolkit.org. So as in neonatal abstinence syndrome, nastoolkit.org. And if you go there, you will see this as the main homepage. And I'm going to walk us through this as logically as possible. So to do that, I'm going to first show you some of the other supplementary features of the toolkit first. So let's go over here to the right upper corner to About the Toolkit. If you click there, you will be brought to the About menu. And you'll see here many documents that are really useful for the folks who are going to be doing the implementation of this toolkit at their site. So, for example, documents that might assist in getting buy-in for a project on substance exposure at your facility. And then also something that we always include in our toolkits, the implementation guide. The implementation guide for this particular project is important because, as we know in substance exposure treatment, we can't just silo it to what's occurring in the hospital setting, but we need to be thinking about what's happening in outpatient care and outpatient clinics and our community providers doing transitions of care work. And this implementation guide will touch on a lot of those details. And then if you were to scroll down, you'll be here in the executive summary. Okay, I'm going to go back up here and I'm going to get back to the main page of the toolkit by clicking on the upper left corner where it says MBSCI Toolkit. And that brings us to the main page here. And I'm just going to go ahead and jump into the best practices by clicking on the big orange bar, Start Your Journey. And we'll start our journey here with all of the best practices in the toolkit. So you'll see here that they are all in ascending numerical order. I'm going to scroll real fast to the bottom. I know folks don't like fast scrolling, but I'm doing it for a reason so that you can see that we have 39 best practices listed. And also, if you were to pull this up on your mobile device, if you were at work and in between patients in the clinic or at labor and delivery or whatever it might be, pull this up on your phone and you'll see it presented in the same easy to read format. I'm going to scroll back up here now, and right here at the, still in the blue toolbar for Start Your Journey, we know that some of you will also want to print out these documents. Nurse managers, for example, really like to bring them to department meetings and so forth. You can click on download all of the best practices as a PDF, and you'll be taken to another window where all of the best practices are listed in one document here for printing. You can also print them one by one, and I'll show you that as well. But let's go back to the toolkit here. And let's go inside of a best practice. I'm going to start with best practice number 1, use a validated verbal screening tool. Click here. And the first thing you'll see is all of these colored tabs pop up: outpatient, labor delivery, nursery NICU, and screening assessment. These are important because this tells you where this best practice lives. So this is a best practice that is pertinent to outpatient, it's pertinent to labor and delivery, and nursery NICU, and the topic is screening and assessment level of care. I will get back to that in a second, but first I want you to see how the best practices are all laid out, how they're all divided up. If I scroll down here, you will see that every best practice is set up the same way, with overview, why we are recommending this best practice, strategies for implementation, and then all of your resources, references, and even authors. If you're in the resources section, every resource is hyperlinked so you can go directly to that resource that we're referring to if you need it. So that is how every best practice is laid out. Now I'm going to scroll back up here and I'm going to talk about these tabs again. So right now we're in best practice number 1. We're talking about using a validated verbal screening tool on all pregnant women. And I want to see, though, I work in labor and delivery, and I would like to see all of the best practices that, that are pertinent to labor and delivery. So to do that, I would click here on labor and delivery, and up pops every single best practice that is useful for the labor and delivery setting. However, it is set up also in terms of topic, just to help divide it up a little bit better so that everything is organized according to screening, treatment, transition of care, and education. Now, there is actually an easier way to do this as well. If I'm on the main page of the toolkit and I'm in a hurry and I really just want to get to the best practices for my site of care, I would simply scroll down. I'd find labor and delivery here, click that, and here I am back at that page looking at all of the best practices pertinent to my site of care. Now let's say that I really don't want to only see what's pertinent to my site of care, and I would rather see things by topic and see every best practice related to a certain topic. You can do the same thing, scroll all the way down. You'll see it laid out by screening, treatment, transition of care, and education. And so, for example, I want to know everything related to treatment. I'm going to click on treatment. All of the best practices related to treatment will come up, but they are also organized by outpatient options, labor and delivery, and the best practices for treatment for nursery NICU. All right, one last thing I want to show you. Going back to the main page, if you scroll down to the middle of the page, you're going to see 2 archetypes or storylines, and that's for Kayla and baby M. If you click into them here on the main page, what you're going to find is a little bit about their history. And that history of each is important because when you are in a best practice, and I'm going to click into a best practice again, go down here to the number 1. If I'm reading through this best practice, I will come across a story for Kayla. In this instance, it's Kayla, but in another instance, it might be baby M. And this is a story related specifically to this best practice of screening. So this is just something we've included to also complement your learning. And now I'm back to the main page. I'm going to stop sharing here. Go ahead, Christina.
Thanks, Holly.
And now, next person up will be Dr. Carrie Griffin. talking about maternal best practices.
Hey, thank you, Holly. So as you all can see, there are quite a few best practices, but we do want to highlight two of the most salient points from the maternal perspective for this toolkit. So the first thing that we'll review is several best practices that reinforce the need for implementation of a universal verbal screening tool as opposed to toxicology testing, as well as identifying what kinds of MAT or medication-assisted treatment are available and why this is the standard of care for opioid use disorder in pregnancy. Next slide. So best practice number one, right? Like all good things in medicine, we start with screening. So we recommend using a validated screening and then assessment tool for any positive screens for all pregnant women. Before we even talk about what validated verbal screening tools to use, I really want to emphasize the fact that the toolkit suggests screening all pregnant women. If we don't screen all pregnant, then our screening for substance use disorder will fall prey to what it has been for decades, which is full of implicit bias. There's bodies of evidence across all disciplines that we tend to screen women of color and lower income more. And we can introduce the idea of screening for substance use just like we introduce screening for HIV, syphilis, gestational diabetes. There's so much that we screen for in the prenatal period. And our recommendation is to make screening for substance use disorder just another part of our routine prenatal care. Furthermore, the earlier that we implement screening for pregnant women, the sooner you're able to identify it. So when this is identified in the first trimester, and perhaps in that earlier phase of the DSM-5 criteria that Corey reviewed, that gives us more time to help actually perform an assessment and then recommend a treatment plan that matches that particular patient and their substance use disorder needs. Next. So what we recommend in terms of how to implement this is to choose a verbal screening tool. We are not recommending a particular one. Within the toolkit, you'll see multiple that are listed: the NIDA Plus, the 4Ps Plus, the SERP-P. These are all options that you can use that have been validated within a body of evidence and can be easily given. The point of a screening tool is that it can be done quickly and will likely yield a positive result if there's a positive result to be found. Now, after you have a positive screen, the next step is to perform a validated assessment tool. These include the ASSIST, the audit, the DAST. These are all options that have, again, been validated, and it's the use of that assessment tool that really identifies whether that positive screen is in fact indicative of a substance use disorder, and it's also these assessment tools that help you figure out the severity of that substance use disorder. Next slide. Great. So you've done your screening, you've done your assessment, and you've had a positive screen, and now you have some level of risk with your assessment tool. The next practice that we recommend is something that is bread and butter in the world of addiction medicine, SBIRT. So you want to perform your screening and then a brief intervention and referral to treatment. Rather than being just like a very strange onomatopoeia, I really like to remind people that brief intervention is actually something that every single one of us does in healthcare, no matter what your role is, every day. And that's essentially a conversation. It's a moment to get transparent, to get real, to get curious about the person in front of you and find out what is their relationship to that substance. How long have they been using? Have they ever been in recovery for any period of time? And what happened to that for them? Find out if they've used any kinds of treatment in the past, and this might be a moment to reintroduce them to perhaps treatments that they haven't tried or levels of care that they haven't been able to access before, and reinvite them into that space. So the other thing that can be helpful about using this process of screening, having your brief intervention, and then referring to treatment is identifying people within your organization whom you can potentially, especially if you're the clinician, do a warm handoff towards. So a warm handoff means actually inviting a third person into the room. This might be someone from your behavioral health staff, it could be a social worker at your hospital, but it's someone who can then perhaps step in and perform a longer assessment to identify a level of care, which we'll talk about briefly next, or might be able to just offer a little bit more direct counseling intervention, hold space a little bit longer than you might be able to as the clinical practitioner. Next. So your assessment tools will have delineated whether your patient has a low risk, moderate risk, or high risk. And as we just talked about, for moderate risk patients, this is where you employ your brief intervention, also known as your moment of humanity and conversation and clear evidence-based recommendation for their substance of choice. Now, for patients who are high risk, these individuals should actually have something called a level of care recommendation made by doing one of the ACAM screenings called the co-triage or the continuum. The co-triage is designed to be a 10-minute screen. The continuum is about an hour. So you do want to have something in place where you've got an individual who's identified and trained in doing these particular kinds of screens. Next slide. When we look at this, so your co-triage and your continuum, again, the screens that you have now given to people who've identified as high risk for a substance use disorder, we could get very far into the weeds, and there's lots of other lectures and places where we can do this. But essentially, if you look from the left, you see less intensive care. So you see outpatient services, which could include an office-based Suboxone or buprenorphine program or methadone clinics. And as we move further to the right, you see increasingly intensive care. So 2 would be intensive outpatient services or IOPs. As you get to 3, you get to residential services. Often when people say someone needs to go to rehab, they can be referring to residential treatment centers, places where people are housed, often connected to other social services, and are simultaneously receiving some amount of behavioral health services. And then finally, all the way to the right, you have medically intensive inpatient services. So this is usually detox. Next slide. So perhaps most important to take away from this webinar today in terms of the maternal practices is that the reason that we're really strongly recommending that everyone apply a valid screening tool to all pregnant women is because this is what tends to happen. We tend to say, well, we're universally doing urine drug screens on all women. The problem is that a positive urine drug screen is not a diagnosis of a substance use disorder, nor is a negative urine drug screen indicative that a person doesn't have a substance disorder. The application of toxicology testing is just as rife with the implicit bias that we apply to our verbal screening tools if we're not implementing them universally. So there's fantastic evidence that when left to our own devices and without creating policies and procedures that encourage us to screen people universally, we screen women of color, we screen women of lower socioeconomic status, and this can lead to some unbelievable downstream effects. Other agencies' urine drug test results perhaps don't know how to interpret them through an appropriate and full-bodied clinical lens, and this can lead to mother-baby dyad separation, perhaps unintentionally and perhaps inappropriately. Next slide. So just to review some of the limitations and to remind ourselves, you know, in clinical practice, we can get so fixated on results, and this is not necessarily urine toxicology testing is not necessarily accurate. There's high numbers of false positives. Many substances can't even be detected, one of the most common ones. Testing itself doesn't actually give you any information on the severity of a patient's use or how long they've been using. And even if your results are negative, you might be missing someone who's still sporadically using, particularly if it's the use of stimulants, which can often metabolize rapidly. One thing to be aware of too is that any positive toxicology result requires confirmation testing. So this often doesn't happen if you're not deep into the realm of addiction medicine. Your actual positive urine drug screen, especially point of care testing, really needs to be sent out for confirmation. Next slide. So importantly, talk to patients about urine drug tests before obtaining it. It's such a violation of trust when we take someone's urine, perhaps for a urine dip or their routine gonorrhea, chlamydia screening, and then we test it for toxicology without telling them. Patients absolutely have the right to refuse testing, and they should not be coerced into having a urine drug screen performed. Instead, think of that as a moment, if they refuse, to go back to the principles of SBIRT and your brief intervention. Why might they want it to be refused? Get soft, get quiet, find out what's actually happening for them when they want to decline having that toxicology test. To reinforce any unexpected results, which means an unexpected positive or a urine drug screen that you're expecting to be positive but is in fact negative for all substances, needs to be sent out for laboratory confirmatory testing. And for those of us who are in the hospital, really important to be aware that when patients come in labor, they may very well have gotten a dose of fentanyl really early, collected urine after that, and then if their urine drug test comes up positive, you have to look back at the time that they received certain medications. Ephedrine and vasopressin are also common causes of false positive amphetamine results. Next. So best practice number 10. Implementing medication-assisted treatment in the prenatal setting. And we said prenatal setting to indicate that this might be a clinic, but it could also be an emergency room, it could be OB triage, just to remind people that the use of MAT in the prenatal setting is now what is recommended as standard of care and first-line treatment. MAT specifically refers to buprenorphine, also known as Suboxone or Subutex, methadone, and naltrexone. Naltrexone, the latter, there's just starting to be some burgeoning evidence that it is safe, both safe to use in pregnancy and that it may also actually likelihood of relapse. But at this moment, Subutex, buprenorphine, I'll call it buprenorphine from this point forward, is really the gold standard and ideal recommendation. There are people for whom buprenorphine is not the best option, and methadone and daily dosing of methadone at a clinic would be preferable. However, I work in rural California. We do not have a methadone clinic. So really being able to MAT exposure is critical. There is just such an abundance about how MAT is wonderful. Corey actually alluded to it. And he was doing is it's stabilizing this neurochemistry. And once you
Hi, Dr. Griffin. We may have lost your connection. I'm going to go ahead and Dr. Griffin was almost complete. Dr. Duplessis, are you on the line?
I sure am.
Why don't you go ahead and finish up this slide, if you don't mind, and the how.
Sure, and I would say also I was just trying to put something in the chat box to remind our listeners, if you're wanting to ask a question about content or something to pose to the panelists, please use the Q&A function rather than the chat function. We're trying to use the chat function only for technical issues. Having said that, you know, when we're implementing medication-assisted treatment in the prenatal setting, we want to be able to identify and know in our community where we have MAT OBOTs, office-based opioid treatment, or other kinds of MAT X-waiver providers who can support women in their seeking of treatment. We also want to encourage prenatal providers to become X-licensed if they have the supports necessary in their practices to provide MAT, but also at least to do that screening, as we were underscoring earlier. And if there aren't any local practitioners, to make sure that you're connected with your drug Medi-Cal organized delivery system at the county level, if there is one in your community, or with other resources that can help you make those referrals.
Hey, Helen, it's Carrie Griffin. Thank you so much. I appreciate that.
Sure.
So last best practice from the maternal perspective is to ensure that MAT doses, no matter what the form of MAT, are not tapered in the immediate postpartum period. So we know that the postpartum time for any woman, let alone a woman with substance use disorder or any mental health disorder, is a difficult time. Women in the postpartum period, particularly at the 3 to 9 month window, are especially vulnerable for mood disorders worsening or starting to exist. It becomes incredibly important to not change part of your substance use disorder treatment, or here your opioid use disorder treatment, during this window when there's so much change happening and there's so little sleep usually happening too. So if your prenatal provider is not the same as your MAT provider, it's imperative to make sure that this recommendation of not adjusting the dose of MAT and not tapering off of it for that first year after delivery has been communicated to the obstetrician, to the pediatrician, to anyone else involved in this family's care. That needs to be reinforced, and that kind of education provided to nursing staff within the hospital, perhaps the residential treatment center staff where a patient might be going with her baby on discharge, but just really being clear that everyone understands who's part of the team for your dyad, that staying on this medication for a year postpartum, or as long as the patient may need it, is critical to making sure that she has stability for substance use disorder treatment. So with that, I'm going to introduce Dr. Ponder, our neonatologist, to talk about the newborn best practices.
Thank you. I'm going to be covering the objectives related to the newborn portion of the toolkit. On the newborn side, as the authors of the toolkit were assembling these best practice recommendations, we try to be mindful of the fact that there's probably not a one-size-fits-all approach to caring for infants with NAS. Newborns with NAS are cared for in a variety of settings, sometimes in a well baby nursery, inpatient pediatric ward, or sometimes a freestanding children's hospital with a level 4 NICU. And we're dealing with a variety of rural and urban settings with a variety of resources available. So we hoped that these guidelines would present a general framework, but the practical application of these guidelines is likely to differ between hospitals. These two objectives really go hand in hand. I'm going to go over a sampling of the best practices in the toolkit related to non-pharmacologic treatment for newborns with NAS, as well as those that emphasize the importance of preserving the mother-baby dyad. The toolkit does cover some guidelines for pharmacologic treatment of infants, which was previously covered in a webinar by Dr. Lee. But I think you'll see by the end of this talk that an emphasis on these concepts of non-pharmacologic care and preserving the mother-infant dyad are essential components to any attempt to improve the care for these families in whatever setting you work in. Next. Best practice number 16 is a recommendation to implement a non-pharmacologic NAS bundle of care for medical staff and parents to follow. We felt that a bundle of care will help to prioritize non-pharmacologic interventions over medication, which will also reduce the length of stay and keep staff and parents aligned on the care being provided to the newborn. There are a number of ways to do this, but it's important to collaborate with nursing and the whole healthcare team to develop a bundle of care that is specific to your unit, ideally with a written guideline that the team can refer to. Just as with any quality improvement changes, it's important to have buy-in and champions for your cause, so this would be a good place to start. Next. An example of a non-pharmacologic care bundle is outlined here. The toolkit goes into more detail, but areas you can focus on include an infant's environment, different feeding strategies, skin care to deal with diaper dermatitis or even skin breakdown that can occur from tremors, and strategies to increase comforting measures. The previous webinar went into breastfeeding recommendations more specifically, but to reiterate here, a mother who is in a treatment program who is taking methadone or buprenorphine appropriately should be encouraged to breastfeed with early lactation support provided, if this is what she chooses to do, as this does decrease NAS severity. Next. For best practice number 17, we recommend that a unit develop guidelines for inpatient monitoring of newborns that do not require pharmacotherapy. More specifically, when a newborn is exposed to opioids in utero and does not require pharmacotherapy, we recommend a minimum of 72 hours of inpatient monitoring. And just to clarify, this may be different than a baby who's exposed to other substances like methamphetamines or THC, for instance, who might be able to be observed for the usual newborn time period. Infants exposed to opioids, however, are not good candidates for discharge at the typical 48 hours or so of monitoring after birth. Depending on your group's comfort level and how reliable follow-up is, some infants may require even longer monitoring, for instance, if exposed to methadone, which has a longer half-life and more delayed onset of withdrawal symptoms. Next. Best practice 18 is to consider parental rooming in with the newborn when a plan of safe care can be implemented. Rooming in or parental presence at the newborn's bedside can reduce pharmacotherapy use and length of stay. This should be done in a respectful and non-judgmental way, and is a great opportunity to demonstrate and reinforce safe sleep habits in preparation for discharge. Next. The evidence supports this approach as well. This meta-analysis analyzed 6 different studies comparing rooming in versus standard NICU care for newborns with NAS. They found that rooming in reduced the need for pharmacotherapy and length of stay without any in-hospital adverse events or readmissions. Next. Best practice number 28 is to continue to establish a therapeutic relationship with parents and caregivers once the infant has been born, and empower parents to be involved with the care of their newborn. Not surprisingly, most non-pharmacologic care bundles have a focus on parental involvement and empowerment, with staff acting more as coaches to help teach caregivers to manage their infant's NAS symptoms, which can continue for weeks or even months after discharge. Involving parents in newborn care early will increase their confidence in managing NAS symptoms, establish healthy attachment to their newborn, and allow them to better succeed in the transition to home. We give some strategies for how to approach this in the toolkit as well. When and how we provide counseling is just one important factor. Next. Written information and signage can be a really helpful way to reinforce these ideas with both parents and staff. Here are some examples of written materials that can help to engage and empower parents to manage their baby's symptoms. Links to these will be in the toolkit. Next. Best practice number 19 is to prioritize measurement of functional impairment as the basis for pharmacologic treatment, initiation, and escalation. The idea here is that subacute symptoms of NAS can continue for weeks or months. Instead of relying on a total Finnegan score that may include points for more mild symptoms like yawning or sneezing, really tailoring treatment decisions to the more detrimental signs of NAS that interfere with a baby's function may help to minimize pharmacotherapy use. Thus far, this does not appear to cause an increase in readmission rates, but we acknowledge that there are no long-term studies at this point to evaluate benefit versus harm of this method. Next. Here are 2 examples of published methods that put a greater emphasis on functional impairment instead of a total Finnegan score. First is a Finnegan symptom prioritization method. Most recent reports include poor feeding, poor sleep, and continuous crying as prioritized functional measures. Other components of the Finnegan score that are sometimes included are emesis, diarrhea, tachypnea, or fever. The second is what's known as eat, sleep, console. This prioritizes when an infant is eating less than an ounce per feed or poor breastfeeding, sleeping less than an hour after feeding, or is not able to be consoled within 10 minutes. There are a number of ways to try to implement such changes to the scoring method used in your unit, and again, it would need to be tailored to meet the needs and acceptability of your unit, and again, with nursing buy-in and collaboration while monitoring for safety. Next. For the last objective today, both Dr. Griffin and I will review how hospitals can support the safe discharge of mothers with OUD and their newborns. Next. On the newborn side, next slide. For best practice number 33, we recommend that you communicate directly with the outpatient primary care physician to review the hospital course and discuss follow-up. Primary care physicians should help to monitor an infant's potentially ongoing mild withdrawal symptoms, feeding and weight gain, as well as making sure families are receiving appropriate resources. We know that in utero drug exposure is at the very least a marker of environmental risk that requires additional support and monitoring. We recommend primary care physicians follow up within 24 to 72 hours of discharge and a home health visit if available. A focus of the toolkit is to consider using discharge checklists, and this is included with considerations for the newborn as well. Next. Within best practice number 33, we reference this study that indicates that the in utero exposure to opioids or other drugs, or what happens before birth, is not the only factor that determines how children do long term, but that the environment they grow up in also plays a huge role. That a child's long-term development is affected by the balance of risk factors as well as protective factors like those seen here. So that even if a child has been exposed to drugs in utero, if they have protective factors like a parent who is involved and attentive, a family that has adequate support and resources, or a supportive community, these factors can protect and improve a child's long-term outcomes. This reinforces the critical importance of making sure that families are supported and connected with the appropriate resources to ensure healthy long-term outcomes for these children and their families. Now I'll hand it back to Dr. Griffin to review more features of the toolkit related to discharge planning for parents.
So I was actually just scanning a lot of your questions, and this particular best practice speaks in some ways to the critical need for it existing. So much of this work, as we discussed, is that substance use disorder treatment does not happen in a silo, right? It's not happening in the hospital alone. It's not happening in clinic alone. Because it is it's a chronic disease that really has such intense psychosocial and thus community implications, it's imperative to have a very clear list of resources that cross the whole community. So what prenatal care clinics are specializing or are developing a program for women with substance use disorders? Who are your MAT providers? Where are the residential treatment centers? Are there residential treatment centers that take mom and baby postpartum? And making sure that everyone is plugged into what's available within their community. Next slide. Relatedly, and this is included in this best practice in the toolkit, find out what outpatient resources are not just local, but what's available on a federal and state level. I feel confident that many of the people on this call are familiar with the home visiting programs like the Nurse Family Partnership and public health nursing in general, as well as programs for newborns like Early Start, Head Start, and making sure that people are identified and referred into these programs as early as possible in the course of their pregnancy. Next slide. And then finally, the last best practice we wanted to highlight today is number 27, implementing an opioid use disorder discharge checklist. So baby has arrived, the postpartum period, again, is such a liminal, difficult potential time. And we don't recommend this practice because we want your hospital to have yet another bunch of boxes that you need to check. Instead of thinking this think of the boxes as an entry to communication more than anything else. This is a way to make sure that the prenatal provider, the OB she'll see afterwards, that any community services that she's involved in, that all of these people are aware of, for example, the importance of staying on a stable dose of MAT, that she's plugged into any of the resources that we mentioned from Best Practice 25. But taking the time to really create a discharge process planning that really couches this mother-baby dyad so that when they go off into the world, they have all the support that they can possibly need. This toolkit is really designed with the goal of keeping the dyad together. It's very clear, and I'm sure that many of you know that one of the ACEs, or adverse childhood events, is separation from primary caregivers. Substance use disorder in pregnancy is really meant to keep moms and babies together and to finally and potentially put a stop to some of the intergenerational trauma and substance use disorder habits that have existed. And something as simple as a discharge planning checklist is a part of how we create safe, reliable treatment for families to stay connected to that larger goal. Next. And I'm going to hand it over to Dr. Wong for her final closing remarks.
Thank you so much, Dr. Griffin. Next slide, please. We hope you have enjoyed this introduction to the Mother and Baby Substance Exposure Initiative online toolkit. This toolkit has been the culmination of over a year of work from contributions by a large task force of experts, and it took the dedication of a small group behind the scenes to successfully be able to launch and introduce it to you today. So what now? We hope you will use this toolkit to spread the word and help achieve better care for both mothers and their newborns exposed to opioids. Here are just some of the ways you can help to make that happen. Promote universal verbal screening and medication-assisted treatment for pregnant women with OUD in a setting that's free of stigma and bias. Advocate for hospitals to use functional scoring and non-pharmacologic care for newborns with NAS. Develop a plan of safe care that preserves the mother-baby dyad. These actions will not only support both mothers exposed to opioids and their newborns, but will also have positive effects on their families, their communities, and our society as a whole. We reach out to all of you to help us in this worthy cause. By working together, we can really make a difference in the lives of these mothers and babies and successfully support the mother-baby dyad. We've listed some excellent resources to help you in your efforts. California Bridge has resources for substance use disorder treatment in acute care services. The California Department of Healthcare Services, on their site, lists directories for substance use disorder services. And at HMA's Addiction Free CA, you will find a variety of resources, including the webinar mentioned by Dr. Ponder several times in her slides. Next slide. We thank you so much for attending today's webinar. The toolkit is located at nastoolkit.org, and you will find today's slides and webinar on the CMQCC and CPQCC's websites and YouTube channels. Please contact Christina Oldini with any comments or questions that you have. And now I will turn it back over to Christina to begin the question and answer portion of the webinar.
Jadene, thank you. And thank you to all of our presenters today. Many questions and comments have been received, and we're going to do our best at covering as many as we can. I'd like to reintroduce our project partner, Dr. Helen Duplessis, Principal at Health Management Associates. Helen will get us started with a couple questions and answers. Helen?
Thank you so much, Christina, and thank you to all of the participants on the webinar today. There were a number of questions related to confusion between the concept of screening and testing, and also related to the relationship between screening, utilization of prenatal care, and fear of child protective services. So I'm going to try to bundle all of those and respond as follows. I would remind us all that it is absolutely true that right now many pregnant women with opioid use disorder and other substance use disorder are coming to the attention of the medical community for the first time at the time of delivery. That's why it's critically important for the inpatient setting to embrace motivational interviewing and trauma-informed care practices so that they can implement good screening practices that are often the entree into relationships with these women. Building a broader understanding of opioid use and substance use disorder as a chronic disease is also a great strategy for actively chipping away at the stigma that is experienced really at every level in the healthcare system as well as in society as a whole. We'll be much more effective, I think, at pushing screening upstream into primary care, and indeed even more broadly into various social services settings, and hopefully getting more individuals connected with medication-assisted treatment and other evidence-based treatments. I think similarly, we all need to work with our child protective services agencies, as we are doing in California, to bring them along as well, recognizing that when we support the mom and baby dyad through preventive practices and other supportive approaches, and honestly, I'm hoping we'll see more and more states doing that through the Families First Prevention and Services Act. We'll do a much better job of making conversations in a more trusting, open environment with various kinds of service providers, more likely to have mothers access that and create a pathway for them into treatment and recovery. Thanks, Christina.
Helen, thank you so much. I appreciate Valerie sitting here with me. We're looking at some of the questions. And I'm wondering if Dr. Griffin, perhaps you could go ahead and speak to a little bit about the timing of screening in pregnancy. So being prenatal care, presentation to labor and delivery, or even a 32-weeker presenting to rule out a UTI. So if you could speak a little bit about the timing of screening, that would be very helpful.
Absolutely. So certainly, we would recommend people who come in for scheduled prenatal care at any point, whether that's first, second, third trimester, perform a verbal screening tool then. That being said, and just like Helen alluded to, the reason that this was chosen for this year's QI initiative is that hospitals need to be engaged in this process as well. And so much of preventive work for substance use disorder involves that critical first step of screening. So training your L&D nurses, L&D social workers to screen patients when they come in for that 32-week dysuria complaint is just as important. Now, additionally, one of the things that's recommended with particular use of the 4Ps or the 4Ps plus is to potentially use that every trimester. Maybe you do it at in an ideal world, your first trimester visit, and then when it's time for your gestational diabetes screen between 24 and 28 weeks, you might do it again then, and then maybe when you do your GBS at 35 weeks. So that's one way about initiating it. And that is certainly a model that certain counties have been using when they implement screening in a broader way for their prenatal care offices.
Excellent. Thank you, Dr. Griffin. Dr. Waller, I'm going to throw one your way. If you could kind of do a general education for us on what is meant by a validated screening tool. Can you speak to what validation means?
Absolutely. So validation is the means by which, by asking a specific set of questions and obtaining a specific score, then this person has a higher probability of having the disease than not having the disease. So these are all the same, no different. A validated verbal screening tool is no different than utilizing a troponin for a non-ST elevation MI. There is a cutoff point that would say anything above this would be representative of myocardial infarction, and anything below this would be representative of low risk of that. It's the same with a validated screening tool, meaning that when you've asked questions, and if I use something like the ASSIST, which is an assessment, if you look at that one, the World Health Organization has validated it not only question by question as to its chances of being fundamentally responsible for giving you a yes, no, as far as do they have the disease or not have the disease, but they've done it in a multitude of different groups of people, including males, females, different cultural settings and different languages. And so the validation in the verbal screening tool is usually deeper than that of even some of the laboratory tests that we use. and the literature for each of those validation techniques and what the cut points are for sensitivity and specificity for each of those is listed as a part of the references in the toolkit.
Excellent. Thank you, Dr. Waller. Dr. Main, I'm going to go ahead and ask you if you can take a moment and discuss presentation in labor. So perhaps a birthing person who's been receiving prenatal care, perhaps a person who has not been receiving prenatal care. Can you speak to the importance of the handoff and really the communication from the prenatal setting to the inpatient setting?
All the handoffs that we've described are very, very important. The handoff from the prenatal provider to an MAT provider, and then for both of them to hand off to the inpatient unit. These patients tend to be fragile with their trust, and there's nothing that creates trust better than knowing that there is a team that's looking out for them. So this is a real important piece, so that the inpatient unit knows what's been going on in the outpatient, both in the obstetrician or family practice office and or with the MAT providers. So this handoff really is a critical one and cements the next handoff, which is the mother and baby going home. We have seen most of the deaths, maternal deaths from opioid use disorder in the late postpartum period. And that's where mothers have not gone back to their MAT provider or coverage has lapsed. And we really, really need to have that handoff be a really strong one for the benefit of both the mother and the baby as the baby starts in pediatric care. So handoffs cannot be overestimated.
Excellent. Thank you, Dr. Main. Helen, I'm going to bring you back for a moment. I'd like you to, we've had several questions actually that identify the theme of self-tapering. In other words, delivered patients who choose to self-taper, perhaps with the appreciation of their physician or not, because of the concern in relation to CPS or CWS. Can you speak to that for a moment?
Right. That's a really important question, and one that makes all of us as physicians very concerned, because on the one hand, we absolutely understand and appreciate the good intentions of moms who want to do the absolute best by their babies. And in some respects, logically, one would think the best thing to do is to get off whatever drugs I may be using so that I'm not putting my baby at risk and exposing my baby to anything exogenous. On the other hand, though, we do know, as Dr. Waller was demonstrating earlier, because opioid use disorder is a chronic condition, what happens over time when someone has that disease is that their ability to respond to and make more dopamine to keep themselves motivated and keep away cravings is diminished for a variety of different reasons. And so when moms try to self-taper, they put themselves at risk for being even further dopamine depleted, and then making themselves at risk for having more cravings and slipping back into a relapse to inappropriate use of opioids. The one thing that we don't want to have happen during pregnancy is a re-engagement of use of opioids and subjecting that mom and that pregnancy to unpredictable spikes and declines and withdrawal that put the pregnancy at risk. So self-tapering is absolutely not recommended. Indeed, the evidence base right now is that even medically supervised detoxification is not recommended during pregnancy for the very same reason the risk of relapse is so very high. We would rather keep mom and baby alive and stable during the pregnancy.
Thank you, Helen. Excellent, I have to say. Before we go to another question, I want to thank Dr. John Wachtel out of Stanford University for reminding us that in the state of California, ACOG District 9 has a wonderful opportunity for 1-hour presentations on OUD. So you can see it there. We will go ahead and include that in our FAQs that are going to be produced after the webinar. We will include the email. You also have my email to go ahead and reach out. So please remember that. We will hook you up absolutely with ACOG so you can utilize that wonderful opportunity. Dr. Ponder, I'd love to, if you could just take us to the newborn side a moment and speak to the idea of consent in a very tough situation where you would like to go ahead and proceed with meconium testing or whatever's appropriate. Can you speak a little bit to that?
Yes, it's a very tough area, and there was a lot of discussion on this while making the toolkit. And I see that question about it, about when we can send perhaps a meconium toxicology testing. The American Academy of Pediatrics doesn't require a written informed consent to send toxicology testing on an infant, but does recommend parents be notified of the need for testing and of the result. And the testing, should be for the purpose of guiding medical care and follow-up and have an impact on the care. So the toolkit does touch on this to some extent, and basically if that information is not available about the mother, and the infant perhaps has some potential signs of withdrawal, and there's concern about potential exposure, in order to best care for the infant, we recommend having a policy and procedure in place of what would then trigger testing of the newborns, toxicology testing. And a lot of the same considerations apply for testing with the infant as was discussed for maternal testing, and that, to understand the limitations that, of both negative and positive test results. They also require confirmatory testing. And so those things definitely need to be considered when you're sending that test as well. The implicit, explicit bias, all of those factors definitely play a role.
Thank you, Kathryn. I'm going to, I think, close it up with one last question here. Please remember that we will prepare an FAQs that will be released. Those will follow up. We will offer follow-up to all the remaining questions. Dr. Waller, I'd love you, before we close this out, to speak because, in our collaborative, in the state, we have 31 hospitals that are participating and actively improving care. I'd like you to speak for a moment on the use of the toolkit in terms of multi-substance exposure. So in other words, we've received questions during the collaborative of, gee, we really do have a methamphetamines problem. We really don't have as big an opioid problem. Or we have, birthing folks using both opioids and methamphetamines. Can you speak a little bit about that and the general usage of the toolkit related to SUD?
Yeah, absolutely. And thanks, for whomever sent in that question, because this was something that we spent CM QCC and CPQCC and HMA spent a lot of time talking about at the beginning, that we wanted to build a toolkit that was designed for infants exposed to any substance. And mothers with any form of addiction, because building an addiction treatment system within a hospital for the dyad of the mother and the baby to be well evaluated and cared for was of the utmost importance, because it's opioids now. Well, for most places, in some places it is meth now. And if you look through there, you will find that there are a few that are specific to opioids, but the vast majority of the ones for screening, assessment, level of care determination, for treatment, as well as for education and transitions, are independent of a specific substance. And so we were really focused on building something that would have a legacy past opioids, and we'll continue to add to this over time, which is a nice variant that Stanford is put out, is to allow for this to be online, so that if we need to add best practices for specific things such as methamphetamine, we can. It'll be a living and breathing document rather than a static one. And so to that end, if you find that there are areas that you don't feel were addressed, we would love to hear about those and would be happy to continue to work on this to make it helpful in all those aspects.
Wow, thank you. Thank you, Corey. I want to thank everyone for joining us today. Before I leave you, I want to remind you that you'll be receiving an email requesting you to fill out an evaluation. Please do. That helps us with future programming and to reflect on the webinar today. I want to leave you with a closing thought. And this thought actually comes from the executive summary in the toolkit itself. And I'm going to read it as we close, because I think it states where our hearts are, where our guts are, and where the science is. The overarching goals of this toolkit are to maintain the mother-baby dyad whenever possible, and to keep the patient in treatment, thereby reducing the incidence of NAS. These goals drive a lucidity of purpose to offer safe, effective, patient-centered, hopeful care that is free of stigma and prejudice. Thank you again for attending, and we wish you a wonderful afternoon.